Um, it's a huge honor and an enormous pleasure for me to be here. I'm overwhelmed with your numbers, and I'm really looking forward to learning more about your work across Queensland. I'm just starting the 5th week in the country. I visited Australia for the first time a year ago and just arrived in Brisbane yesterday, so I'm new to this environment. And I also am cognizant that my accent isn't your accent, so if I speak too quickly or if you can't understand what I'm saying, please raise your hand and let me know. I've got a presentation today that is going to start out talking about how I got into healthcare, so you know a little bit about my motivations and my orientation. And then I'm going to talk about some of my deep beliefs about why engaging with the healthcare system is really important, why users are. And I want to end up by telling you a little bit about the kind of work that I do, because there's a huge variety of activities that I've been involved with. And I'll just add about the championship that I have. It was the first year that that award was ever given to anyone. And we're all in this together. I'm helping them learn. It was a bit of a gong show, actually. They didn't allow me to say thank you or to give a little talk, because of course that was the propaganda opportunity I wanted to have when I did receive the award. But since then, I've of course used that as leverage to open other doors and have access to other audiences that are important to reach. And I'll give you a sense of the breadth of that. But again, it's just a pleasure to have a leisurely morning with you. I'm more than happy to stay as long as anyone here wants me to stay. So on to disclosures. I work as a volunteer. I don't receive income from the work that I do, and to me it's a real privilege to be able to do that. But I believe passionately that I'm there to open doors and to pave a road for people who can't afford to leave work, to leave family obligations, to disconnect from the rest of their lives in order to act as an advocate. So my bias is very much the bias of the patient point of view, the family member point of view. I don't have any conflicts that are of a financial nature or anything else in anything that I'm producing. So the big ideas that I'd like to have you take away from today's session are that healthcare is about a relationship, not a service delivery model. And I hope to be able to illustrate why I believe that. When we're talking about healthcare, they're relationships of trust. And if we want to improve healthcare, it's about strengthening those relationships. And they are reciprocal relationships of trust, not one way. So I'd like you to introduce my husband, Nick, to you. Nick and I were together for 35 years. We had a remarkable relationship. Because we were 20 years apart in age, we didn't waste any time of putting our enjoyment with each other off, and we did have just a fabulous time. Also, because of that age difference, I was more prepared for him predeceasing me than many couples are. When we first met, I was 23, he was 44. We fell in love, a very odd couple. And the first conversations we had, at the moment we realized we were really in love, was, is this fair? Is this a good idea? And Nick would say to me, I'm going to be an old crock and you'll be in the middle of your life. And you know, he didn't want to be a weight on me. But the other thing we talked about is preparing the other guy to survive the other one. We knew mortality was real. So Nick taught me how to repair the furnace, and I taught him how to make bread, and there were lots of other examples like that. So mortality was with us for 35 years, the knowledge of that. And I've lived for now it's 30 years, in a small community in a little island off the coast of British Columbia. And there are lots of retired people there, and all my best friends die. So understanding mortality and embracing that idea, understanding we all get to do that. We don't get to choose how we do it, but we get to do that. So when Nick did die, unexpectedly, 8 days after successful surgery, I felt that I was walking through a threshold of a doorway, and that I was never going back. And it was kind of with a sense of wonder what this is going to be like now that that day has come. So I got the phone call at 4 in the morning from a nurse I'd never met. The nurse who I did know, who was on duty that night shift, was unable to collect herself to make the call to me. So I got to the hospital. It was in the city, and about 2 hours later I was approaching the hospital, and there she was outside. We embraced, she wept, I wept. She told me the things that you have to say, you know, that Nick didn't suffer and all that sort of thing. Went upstairs to the ward in the hospital, and the nurses are bawling. They're weeping. And they have to know it's okay. So I embraced them, and their chests are just throbbing with sobs. And I'm the one who's whispering in their ear, where there's life, there's death. And then I tell everyone that Nick had a wonderful life, that he achieved his life ambitions at 22 when he qualified as aircrew. He was a career Air Force pilot. And he lived a very joyful life. Yes, he wanted to live more years, there's no question. So his surgery had been for a sarcoma, a soft tissue tumor on the back of his leg. It wasn't a vital organ. And I won't go through all the experiences of that week, but Nick experienced successful surgery, had good strength and movement in his leg, but the complications were common complications after surgery. And it's not common for people to die of those complications. Post-operative delirium, which caused sleeplessness, C. difficile infection, which caused nausea and vomiting, but also they didn't feed him for a week. So he's sleep deprived and malnourished. And because the surgery's on his leg, he's stuck in bed. So his respiratory distress from a 7-hour surgery begins to decline. So all these things going on, they compounded each other. And tragically, they were fatal for Nick. But the nurses that morning had given exceptional care, and I felt such gratitude to them. And each of the surgeons came by that morning and paid their respects to me and expressed their condolences. And I expressed my gratitude to them because their surgery had been brilliant. Why do I have a train wreck here? Well, in each picture, one person died. In the train wreck in 1894, I think, 1895, at Gare Montparnasse in Paris, a locomotive coming in from Brittany was behind schedule, and it sped ahead to meet the schedule. And the engineer knew that the Westinghouse air brake would enable them to stop in time. So they're coming into the suburbs ahead of the speed limit, and they apply the Westinghouse air brake, the emergency brake, and they fail. So the locomotive plows through the barrier at the end of the track, across the concourse, crashes out the front facade, falls down onto as you can see, onto the plaza down below. And there was a newspaper vendor, actually the wife of a newspaper vendor, who was taking her husband's place that morning, and she was killed by the falling debris. Everyone on the train had jumped out. They weren't injured. Well, the difference in the two is that in the case of the crash of the locomotive, the railway train, in Paris, there was an investigation, and you can see here there are people from the train company wandering around, and they've put up stabilizing sandbags, and in the distance, if you could see well, there are these Paris firefighters with these enormous brass helmets and plumed helmets. So there was an investigation, and there were remediating actions taken about the use of brakes and the speed limit and so on, and there were punishments meted out, and the children of the newspaper vendor were given bursaries for their education as the financial penalty. But in Nick's case, I was left on an empty stage. After that one day in the hospital to say goodbye to the body I knew, the man had left, I never heard anything more. This was not considered an adverse event. There was no investigation, no case review. And what bothered me more than anything is that those nurses were hung out to dry. They were never told why their patient had died. The surgical team in the operating room never found out that their patient did die. And I thought this didn't meet my concept of medicine. I was new to medicine. Nick had been very healthy. I'd been very healthy. And those encounters that Nick had been like magic. heart pacemaker. It's implanted and suddenly he's fine. His arrhythmia has disappeared. Number of common comorbidities of a 79-year-old. But my idea of medicine was that it was a profession, that it was accountable, and that there would be closure for the people who did what I couldn't do. I'd last about 15 minutes in a nursing shift. I don't know if my empathy bone has osteoporosis, but I find it very difficult, and I really couldn't do that work, so I have so much respect for people who do choose caring professions. So I began to read, and I bumped into words like these, and the idea that a patient might not be safe was not a concept that I was aware of. Now, I don't think I'm totally naive, and I think there are many members of the public who feel the same way about medicine, that you're safe when you're in the hands of doctors and nurses. But the literature says otherwise. The idea of quality and healthcare, the two words didn't seem to go together for me. Quality of care, quality of big, small, the quality of hot, cold. What was quality? Oh my God, bad quality. Again, it didn't compute for me. How could we take people who are heading into medicine with no intention to harm, but only to help, to provide healing and to provide hope? How could we fail them and punish them for investing emotionally in the care of their patients? And I knew that that had been the situation with Nick's care team. If I'd been asked the usual patient satisfaction survey questions within a few months of Nick's death, it would have been 10 out of 10 because his care team cared. They cared deeply about him. But what I didn't realize until I began to read was the literature around the second victim. And because there is a blame and shame culture in medicine, it's the hidden curriculum of not accommodating the bereavement, the grief, the sense of failure, the embarrassment, the shame, because we're talking about a continuum of care failures. The toll that this takes on healthcare professionals is profound. So for example, people leave the profession because it's not what it's cracked up to be. It's very painful, not acceptance from their fellow team members. And very sadly, everyone in the profession can tell you that there are their colleagues not too far away from home who have taken their own lives because of the tragic experience of being involved as a professional in a failure of care that was not handled well. I've read recently that psychiatrists have a higher suicide rate than their patients. How can this be, that we abandon people who do this for a profession? So I read more about patient safety, and I ran into these kinds of statistics. One in 4 hospitalized Medicare, these are all American studies, but it's commonly repeated in other countries. So 1 in 4 hospitalized Medicare patients suffering harmful medical events, far more than detected by the patient safety systems, error reporting systems. And 44% in that particular study were judged to be preventable. And then, the next study found 1 in 3 patients suffering medical harm, and many were multiple cases of harm. And again, the failure to detect those events causes me to really wonder if that's 1 in 3. Would that be true everywhere we look? And the third study here was 1 in 6 patients who were admitted to 10 hospitals suffered more than one or more patient harm events. Most of them were preventable, and again, it was far more than the reporting systems recorded. So this is duplicated in every country that does retrospective studies. So this was a study that came out this summer, and the only point here is that Marty McGarry at Johns Hopkins found in a study that he did that was quite extensive, that in the United States, medical error is the 3rd leading cause of death. Now, how phenomenal. And yet, we have this level of trust in medicine. So this was the kind of picture that I began to think about. That's what's in the patient safety system. And patient safety focuses on the visible stuff that doesn't go well. But underneath that, it's held up by enormous harm that's actually experienced. And I developed this idea, this couplet, that patient safety is a system experience, but patient harm is a patient experience. So if you want to know about safety, if you want to know about the underlying harm, you've got to talk to patients. And that's not the way our patient safety systems are structured. Don Berwick, you may have bumped into, he's the founder of the Institute for Healthcare Improvement in the US and a really compelling speaker. And a number of years ago, I only started when I turned 60 in 2010, but shortly after that, I remember watching a video that was a few years older. And he talked about his wife being stuck in the basement of a hospital near midnight awaiting some imaging because that's when it could take place. And she had some mysterious symptoms. The diagnosis wasn't at all clear. And Don was not allowed to be with his wife because the hospital rules said it was after hours and he could not be with her. And she was alone on this stretcher waiting for the tests. She was frightened, of course, and he, as a physician, was furious that he could not be the person he needed to be to the most important person on the planet, and that was his wife. So he told this story about 10 years after the fact, and yes, she was diagnosed and had recovered and was an environmental lawyer again and being productive in the world and his greatest partner. But Don didn't talk about that as a patient harm or a patient safety experience, but he was clearly harmed. 10 years later, the patient has recovered, but the harm endures. So happily, a year ago, there was a paper that was published that began to acknowledge what I've been saying for a while. And this is at a hospital, project that was done at a hospital in the Boston area, a really leading hospital, Beth Israel Deaconess. And what they identified in this particular study was disrespectful treatment as being harmful. Well, as I said, I've been talking about it from podiums like this for a number of years, but I was delighted to see it, and I've actually met the researchers now. And the little pull quote that I've taken out of the article is, it makes reference to the 1999 To Err Is Human report that really was the boost start for the modern patient safety movement. And it says, in terms of disrespect, in terms of harmful treatment of patients from disrespect, we're back where we were in 1999. We're just at the dawn. And I would say most patient safety systems don't look at that harmful behavior as being a legitimate reportable incident. So this, again, predates that article, but this is a little cartoon I drew of how I look at patient safety. That there's an enormous amount of patient harm that's endured. And it's everything from not being welcomed by a receptionist as though you had a problem. You know, well, I'm never going to take my kid back to that place because they yelled at him, right? So it changes behavior, it changes people's future access to good medical care. It's not just, oh, Carolyn, you just want a cozy bedside culture. No, it's deeply affecting to the people who experience that harm. So out of all the harm that's endured, there's a small amount that's noticed by the system, and of that, there's a even smaller part that is explained and announced to the person who's been harmed, the patient. And some of that enters our patient safety system, but some of it doesn't, because, well, it really wasn't that serious. And you know, I told the patient, well, we didn't give them their medication within the 4-hour window. We were a little bit late because we were so busy. That's not really harm, so it doesn't go into the system. But of course, there's some harm that's not told to patients because, oh, we wouldn't want to upset the patient by telling them that we made a mistake. So the system doesn't really address this issue of the damage to the professionals, that patient safety oftentimes leaves the protagonists in a terribly vulnerable spot. My idea about patient safety events or patient harm events is that when the bad thing happens, it's so important to look at trust and the way trust, which binds us together, can be fractured. I think that's perhaps the most important initial impact. There's the physical insult, but there's the surprise of it. We didn't expect to be harmed. How that's handled is pivotal to everything else that happens. And I put this matrix together a number of years ago, and I know it's a lot of words on the slide, but the 3 rows are identifying 3 different kinds of harm. There's the harm to the patient and their family, the immediate harm. The second row is the so-called second victim, the healthcare professional who's involved in some way in a harm event. And there's the third victim, and that's the manager or the administrator for a healthcare system. And an example of how they might be exposed to that medico-legal danger is endoscopes that haven't been reprocessed well over the last number of months. Suddenly it's discovered they are a large-scale harm potential. So that manager has to send out 2,000 letters to people who have had endoscopies saying, we need you to come in and get your blood tested for hepatitis. So that's the danger at that large scale. So that's called first harm in the literature. But there's also a second harm, and that second harm is if the first harm isn't addressed. In the case of the first victim, the first victim has experienced the damage, if you like, but if it's not addressed, that harm morphs and changes into a feeling of betrayal, right? I trusted I was in good hands and you haven't been accountable, and I feel betrayed. Well, the second victim feels that same sense of betrayal, if you like, from the system in which they place their own security as professionals, in their coworkers. They may feel betrayed by their coworkers. And the third victim as well can be exposed to terrible failures of trust because it's the public trust. And a wonderful example is Mid-Staffordshire NHS Trust in England that some of you may have read about. There were grievous poor care events, and in fact a culture of poor care for many, many months, and in fact years, and some national inquiries into how that could have possibly happened and then perpetuated, to the extent that Mid-Staffordshire no longer exists as the name of a health trust, because the public trust in Mid-Staffordshire had so completely disappeared that the health services in that region of England has a different name now. So one of the interesting things about trust is that once it's hammered, it's shattered, and it's very difficult to put back together. Once you have that sense of betrayal, it's very difficult to recover trust. But I have an idea about how that happens, and my idea is, well, the first thing when the bad thing happens is you look at that smoldering fuse in the cartoon, that make sure that the harm isn't continuing. Halt the bad process, the harmful process. So you secure the victim. But you have to really pay attention to the fractures that are possible in trust immediately. And it's a unique process with every dyad in a harmful experience of doing a ritual, really. It's a dance of disclosure, apology, and forgiveness. And when you meet, and you've probably had this experience yourself, those users of healthcare systems who are active often have, of poor care, you may be really angry, and you've certainly met patients and their family members who are angry about bad care. But the anger is really a desperate plea to reestablish trust. I need to trust again, and to have the bad feelings stop. So we do that in this ritual dance, I think, of receiving an apology, receiving an explanation, receiving an undertaking that this will never happen again to another patient because we've done this to address it. We're going to do our very best to make sure that this is not repeated. But then to be able to accept forgiveness, because that's the generosity from the patients that the patient absolutely wants or the family member wants. And you know, we know from all the literature that apologies are not catalysts to litigation. Apologies are a catalyst to forgiveness. And people who have been harmed do forgive the most extraordinary errors and poor care events. So in fact, it's not all dyads. Our care experience is complex, and I could talk about this little cartoon in many ways. It's who's in our network of care. It's our family practitioner, but it's also the receptionist there, the people who keep the office clean there. It's the people who supply the equipment in our family practice. And it's the bus driver who gets us to our appointment on time. Within the healthcare system, those physicians too have networks that are incredibly broad and wide. And they change over time. They're complex in every dimension. So we're in a complex adaptive system called healthcare. And when one thing changes in one part of the system, it has echoes throughout the system. I want to read one quote, and it's a little bit long, but it's from May 2013 issue of the British Medical Journal. And I know I'm mindful of the time going on, but I hope that this is worthwhile. So in May of 2013, a very strong editorial accompanied this fabulous cover, Let the Patient Revolution Begin. And the editorial is, I've never read anything quite like this. Despite the best intentions and undoubted skill of many who work within healthcare, access to care and its quality vary markedly. Most people in rich countries access a confusing smorgasbord of tests and treatments whose merits are hyped and harms are underplayed. Patients lack information on practice variation, the effectiveness of their care, and the extent of medical uncertainty. Practice is informed by an incomplete research base, bedeviled with selection and reporting bias, and at worst, by fraud. The preservation of institutional bureaucracies, as well as professional and commercial vested interests, have consistently trumped the interests of patients. The healthcare industrial complex stands accused of losing its moral purpose. The corruption in the mission of healthcare requires urgent correction, and how better to do this than enlist the help of those whom the system is supposed to serve, the patients. Far more than clinicians, patients understand the realities of their condition, the impact of disease and its treatment on their lives, and how services could be better designed to help them. So that call to arms is pretty extraordinary. And I think that it is what's underlying the work that you do and the work that I do. Well, who's the system? The system are the individuals we interact with all the time, and they're also being failed by this artificial momentum within healthcare and lack of integrity within healthcare. So I feel commonality with these people. I think that we're all in this together. When you think about what provides security for the healthcare system, I want to challenge, where's the patient in the normal structure, the way things go? We have the organization, we have the professions, but the patient voice has to be there as well. And I think we have to cobble it onto the existing structures. And we'll figure out how to do it better over time. But for now, it's oftentimes kind of jerry-built. So, the citizen patient. Now, here's my definition for the citizen patient. Why I've labeled myself that. I mean, I came up with a phrase and I read it later elsewhere that wasn't defined like this at all. But it's self-selected. So I've selected myself out of the crowd. I've put my name forward, and I'm interested in system change. It's not about changing whatever happened to Nick. It's about looking at change from a much wider organizational standpoint, structural system standpoint. I call myself a citizen patient because for me it's an act of patriotism to want to change the system. It's altruistic. It's not about my care tomorrow or my care next week. I've lived a very healthy life, thank goodness. But it's about living in a community that has access to excellent care. So that's the nature of that citizenship. I use the word patient because in Canada, that's the word that's used, however imperfectly, to describe all these different kinds of users. And it's not individuals, it's networks, it's communication amongst us that enable us to access care. So it is the client, it's the resident in long-term facilities, it's the volunteer who helps out people in their own neighborhood. It's the public who pays for systems like yours and in my country. You have more private care here, but we both share a heavily publicly subsidized healthcare system. So it's the taxpayer as well. In my country, there is such a loyalty to our healthcare system. I think it's because across the border in the United States, there is no system. And Canadians will commonly identify themselves as distinguished from Americans because we have a healthcare system. In fact, Canadians don't know that much about the limitations of the healthcare system. We, for example, don't have a national pharmacare system. So the cost of drugs outside of hospital can be extremely onerous. We also do not have long-term residential care as part of the public system. There are all kinds of gaps. Our family practitioners are by and large small businesses, individuals who are running on a fee-for-service basis, a business to provide primary care. But Canadians do believe that it's important to live in a society where everyone has access to great care, and I'm just part of that sentiment. So when the system hears a person like me coming their direction, there's this kind of response. Oh, they're just going to complain. And you know, we don't need that. We don't need to feel another layer of offense because it's hard enough doing the work we're doing now. In fact, every team of healthcare workers that I've ever been around who have had engagement with patients will say, we're never doing it again any other way. It only takes one experience to understand the value of the consumer voice in the room. Well, everybody in outer society is talking about the interests of patients in the healthcare system, partly because the baby boom generation, my generation, is experiencing poor care with our parents. We don't want to have that kind of care for ourselves. And there's a great deal of I guess it's egotism from my generation that we actually think we can change the world. The world has always rotated around our navel. It shouldn't be any different now that we're becoming seniors. So that activism is going on, and I think it's a real opportunity for system transformation. Well, to do this work, we need everybody at the table, and we need the free flow of information. There is strength in diversity, so having as many different kinds of voices in the room is hugely important. I look like an awful lot of patient volunteers. Mainstream, white, well-educated, articulate, money in the bank, time on my hands. There are a whole bunch of us who dominate the patient advisory committees and boards. However, I would say that it's our responsibility to ask the questions on behalf of other patient groups. It's our responsibility to enable tapping community groups and other kinds of structures within our society to adapt that conduit for information into the healthcare environment. Our communities are part of that citizen-patient network. So it's the person who looks after the Aunt Dolly who lives alone once a week just to drop by to see if she's okay and needs something from the store. It's the other mother at daycare who can take care of my granddaughter when I can't pick her up at the end of the day because I have a doctor's appointment. You know the kinds of structures. So the structures that enable us to be patients, to be participants in the healthcare system really involve our entire community. And these are networks of trust. So briefly, these are some of the kinds of roles that I've done in my brief career, my not quite 6 years, well, just over 6 years of 6.5 years of making the commitment. I decided I wanted to, well, I struggled to make that commitment. I was turning 60 and I thought, Do I have the courage? Do I have the courage to do this? It's going to take a decade. It's not something that's going to happen in a minute. So I've devoted my 60s to, when I turn 70, I'll look back and think, I wonder what that was all about. But I can tell you that now, 6.5 years into it, I would not have believed we would be where we are in my country and globally. And I've had the great privilege of doing work in Nordic countries, in the UK, and Spain, and I'll be going to Japan in a few months. I'm pretty excited about that, and of course in Australia and in New Zealand, and a bit in the US, remarkably. So I'm most proud of the faculty status I have at the University of British Columbia. Unbelievable. The head of the Department of Family Practice said, "Carolyn, do you want a desk?" when I asked him some awkward questions at a conference, very politely. But he offered me a desk. I said, yes, but I had no idea what I wanted. About 3 days later, I said, you know what I really want is a library card, because I'm faking the identity of a neighbor who's a retired professor, because I want to read the peer-reviewed journals, and the pay barriers are exorbitant. I can't do that. So he said, sure, I don't see why not. Talk to my administrator, we'll get you a library card. And she said, well, we'll just make you a faculty member. Really? Is that all it takes? So that was pretty wonderful, and it's also opened the door to doing a lot of things within the university. I won this award, and I've told you a little bit something about that, and I've used that as leverage. It's not about ego, you know, it's about trying to ensure that as many doors are open for as many people. I mean, I have precious little to say as a patient, but I believe so passionately that the patient voice has to be in the room. And that's why speaking to you today is such a thrill. So I've been an advisor on national programs that involve patient and family integration and improvement, and that was terrific. I was a coach to teams. I've worked on various advisory roles within my own province. Registered Nurses Association was reviewing how they would do their regulations and wanted to have a focus group. So those, you know, even small things, a couple of hours put in for that. Public speaking like this, I'm not afraid of anyone. No, I don't have stage fright, and whatever enables the movement to advance, that's what I want to do. And being a team member on a project team, thrillingly, being brought in at the first meeting for an improvement project in a hospital, there were 6 healthcare professionals around the conference room, conference table, and 3 patients. Yes! Fantastic. The team had never met before. It was their first meeting. And of course, the first thing we said is, no acronyms, please. We don't understand your environment. You have to use the whole long. Turns out some of the other healthcare professionals needed some of those acronyms translated as well. This cartoon is my favorite, I think, my favorite drawing of all the drawings I use. And to me, this is the network of trust that enables us to make healthcare work. It requires diversity, it requires overlapping skills, reliance on each other. You don't have to be there every time, but we need this kind of network in order to succeed, whether we're professionals or whether we're patients. And very recently, I've had the privilege of being able to teach the next generation of healthcare professionals. These are students in the medical school at the University of British Columbia. So, connecting up patients with the healthcare system, is this really the answer to improvement? I would say no, of course it's not. But I think without it, we're scuppered. Without it, we're never going to get a healthcare system that provides the professionalism and accountability and high quality experience for patients, but as well for the professionals. When I first started out, before I decided I wanted to be an activist, but shortly after Nick's death, I thought, you know, if all I do is create a happier environment for the people who have chosen the caring professions, I will have done more for better care for patients than anything I could possibly do. And so I think this kind of engagement and understanding each other's perspectives is absolutely critical. Don't worry about whether you have specific skills to offer. You do by your unique perspective and by the trust that you offer. So I've talked longer than I was asked to talk, but I do want to stop now, and I'm more than happy to talk over the tea break and afterwards. Thank you.